Okay, so this particular topic is about diverticular disease. I'm going to start with a few definitions, an introduction, and so on. So let's just get straight into it. So a diverticulum is an abnormal sac or pouch protruding from the wall of a hollow organ. Now, a true diverticulum of the intestine is composed of all of the layers of the intestinal wall. The diverticula, however, which occur in the colon, those are just protrusions of the mucosa through the muscular layers of the intestine. And as such, they are devoid of the muscular layers. And in truth, what they are is that they are pseudodiverticulae. But this is a term that's used to describe the condition diverticulosis or diverticular disease. Now, it's quite common in the Western Hemisphere and was initially observed in the early 20th century. It's much more common in older age patients, and it's one of the most common findings on a colonoscopy. About 15% of patients with diverticular disease will require surgery at some point in time. It has a fairly low to common prevalence, 2.8 per 100,000 of the population, but most of those patients are elderly, they're over 70. And while a lot of patients can be found to have diverticulae on sigmoidoscopy, only about 10 to 25% of those patients that will actually develop symptoms. In the West, diverticular disease typically affects the left side of the colon, whereas in the East, there's usually right-sided involvement. And in the Asian population, the right side of the colon is also predominantly affected. And it also occurs in younger age groups as well. So that's a little interesting tidbit on the differences in the distribution of these diverticulae in the colon in different populations. Patients who are over the age of 60 are at high risk of diverticular disease, especially so those who have low dietary fiber, who are not quite active, and who are obese. It's also more common in females than it is in males, and we're not exactly sure why that is. Now, the pathogenesis of diverticular disease is likely to be multifactorial, probably has a little bit to do with fiber and the diet, probably has a little bit to do with obesity, to some extent genetics as well as the colonic wall anatomy and the motility. Yeah. So we'll look firstly at colonic wall uh, motility and its anatomy. So these diverticula, as we said, they're basically these mucosal herniations through the muscular layers in weak points of the colonic muscular wall. And it usually occurs where the arterioles enter. They happen to occur on the mesenteric side of the antimesenteric taeniae. And what that means is that there's three taeniae. So there's taenia omentalis, taenia libera, right, as well as taenia mesocolica. And taenia mesocolica is exactly where the vessel comes in. It's the vessels coming in from the mesocolon. And so these diverticula, they don't happen here because this is uh, the antimesenteric side. They tend to happen over here on the mesenteric side of the antimesenteric taeniae. Yeah. Most commonly, they're found in the sigmoid colon. About 50% of the time, you can find them there. And if you don't find them there, they're going to be in the descending colon as well. Only 5 to 10% of cases actually involve the entire colon. So that's a very important thing to note. It was thought that it was high intraluminal pressures in the colon that actually leads to this herniation. So the theory is that if you have a large volume of fiber, then the contractile force that's required to propel the feces through the passage is actually quite low. But if you've got low fiber in the diets, then the contractile force required is high. So those intraluminal pressures are chronically quite high, and they can get as high as 90 millimeters of mercury. And so it's thought that that is what leads to these herniations through these quote unquote weak points. But a lot of studies looking at this have very conflicting results. So that's just one theory. The other theory, of course, has to do with the role of dietary fiber, and it interlinks with the colonic wall motility theory. So it's been found that those in the native Africans with a higher dietary fiber and shorter transit times tend to have less diverticulae, less likely to have diverticular disease. But again, it's very controversial. Um, Now, as we said before, because of the geographic distribution of these diverticulae, being different in the east and the western side of the world, one must wonder whether genetics plays a role. And it is thought that to some extent it does, because twin studies have shown a little bit of a relationship. There's also a few theories rolling around about vitamin D, but the role of vitamin D in this is very unclear. In those patients with obesity, what has been noted is that there's positive associations between BMI, waist circumference, to waist to hip ratio, and the risk of diverticulitis. So not necessarily, it's not, it does, these studies don't necessarily say that being obese, having a greater waist circumference and so forth, put you at an increased risk of developing diverticulae. But that what they are certain of is that it seems to increase the risk of developing diverticulitis, which is the clinical entity well, one of the clinical entities rather, of diverticular disease. So how do these patients tend to present? Well, a lot of the time they give a history of constipation, left lower quadrant pain, and it's usually relieved by the passage of flatus or stool. Sometimes that pain may radiate to the suprapubic area, the left side of the groin, the back. Uncommonly, it may also occur in the right lower quadrant, and in those cases, it can be quite difficult to differentiate it from appendicitis. Fortunately, in this part of the world, we don't have to make that distinction too often. Sometimes they can have abdominal distension, fever, and chills and urinary urgency happening as well. And this happens because sometimes you can get a bit of an ileus with the amount of inflammation that's going on there. When that inflammation affects the bladder, you can get urinary urgency as well. And in the cases of infection, if there's a fistula, colovesical fistula, which is actually the most common type of fistula that can result from diverticular disease or diverticulitis, those patients can have dysuria, frequent UTIs, pneumaturia, and fecoluria is also highly suggestive of a colovesical fistula. If you've got fecal and vaginal discharge, then that may suggest a colovaginal fistula. And in those patients that have severe crampy, watery diarrhea, weight loss, and pain, that may suggest a coloenteric fistula. It's also known that diverticulae bleed. Yeah, this bleeding, it's normally painless. It's normally of a large volume, dark red. It may be associated with symptoms of anemia, sometimes hemodynamic instability as well. And so that's a very important aspect to look out for. And diverticulae can also lead to strictures. So you can have symptoms of obstruction as well, failure to pass stool, flatus, abdominal distension, a little more uncommonly vomiting. Yeah. When you examine these patients, there's tenderness in the left lower quadrant of the abdomen, sometimes guarding. In those patients who are peritonitic, they may be tachycardic, hypotensive, pyrexic. If you can palpate a mass, it might mean that there's an abscess or there's a phlegmon in the abdomen. If you've got abdominal distension, as I mentioned before, it can indicate an ileus. Doing a rectal exam is also very important in these patients. It may be able to reveal evidence of a pelvic abscess, especially if you've got a tender fluctuant mass. And the same sort of goes for the vaginal examination of female, although it is not indicated for every case. When you investigate these patients, there's a lot of basic blood investigations to do. Your CBC, CRP, RFTs, LFTs. Your ABG may show metabolic acidosis in these patients. In terms of further investigations and imaging, if you've got a perforation, sometimes something as simple as an erect chest X-ray will help you to demonstrate a pneumoperitoneum. We've got that here, the diaphragm on the right. More commonly, you would do a CT abdomen and pelvis with IV and luminal contrast, and that's the gold standard for diagnosis. It helps you to assess the severity of the disease and therefore put it into one of those hinchy stages of the disease. It can also help to show you the degree of contamination, the size of the abscess. It can help the interventional radiologist determine whether that abscess can be drained percutaneously. It can help to rule out any coexisting malignancy or obstruction. So it's a very highly sensitive and specific investigation that can be done. And so it's very, very important. Ultrasound and MRI, those are viable alternatives, but they're used much, much less often. Yeah. Now, anytime a patient has an acute attack of diverticulitis, follow-up endoscopy is indicated. Now, the reason for this endoscopy is to rule out a polyp, a precancerous lesion, or cancer in bowel. And so it's standard. It's usually done about 6 weeks after the initial or an attack of diverticulitis. Now, doing a colonoscopy in patients who have diverticular disease, can be quite difficult, very difficult to find the main lumen, and you find yourself running into all of these diverticulae and so forth. And so if you're unable to complete your colonoscopy as a result of those difficulties, then a CT colonography is actually quite a viable alternative for those patients. The special interest group in GI and abdominal radiology has actually shown to be quite comparable to endoscopy as well as barium enema, but we don't use barium enema anymore, really. So it's comparable to endoscopy, which is quite interesting. So getting into the Hinchy classification, because this classifies the severity of the disease, really, and it helps to guide our management. Yeah. So we have the original Hinchy classification, and then there are a few modifications along the way by Scher and Wasferi, and that's what we use as a guide. So this is the original Hinchy classification here. Hinchy 1, you've got colonic inflammation and a pericolic abscess or phlegmon, and that's confined, it's right there. 2, you've got colonic inflammation and either retroperitoneal, intra-abdominal, or distant pelvic abscess. A Hinchy 3, you've got purulent peritonitis. A Hinchy 4 is where you've got feculent peritonitis. Yeah. Scher modified the classification by splitting up a Hinchy 2 into 2 parts, and basically a 2A is an abscess that is amenable to percutaneous drainage, and a 2B is one complex abscess that's associated with a fistula. And the Wasferi modification just simply divides stage 1, 1A and 1B, and differentiates between a phlegmon and a pericolic abscess. Now, whether the Wasferi modification has any bearing on management, the answer to that is not really. It doesn't. But the Scher modification does, because it speaks specifically to percutaneous drainage for Hinchy 2A. And then Prof. Narayan Singh also proposed a new classification, modification rather, where the Hinchy 4 is divided into 4 subgroups, where 4A is where you've got a healthy bowel segment. 4B is if you've got healthy bowel with adhesions, but there's no thickening of the wall. 4C is where you've got scarring and bowel wall thickening, as well as mesenteric contraction. And 4D is where you've got a mass and stricture. Yeah, and to some extent, these factors may also play into your management as well. So we'll start with the basics. Uncomplicated diverticulitis. So this is diverticulitis that's not associated with intraperitoneal perforation, fistula formation, obstruction, or anything of that nature. And it is usually indicated or diagnosed by 1 or more extraluminal bowels on the CT. The basic treatment for this is bowel rest and IV antibiotics, and those patients will usually get better in about 24 to 48 hours or so. Patients who've had their first attack of diverticulitis, that is uncomplicated diverticulitis, the treatment is non-operative. You give them the antibiotics. Once they resolve, we recommend that they have a high fiber diet. The risk of a second attack in these patients is 25%, but only 5% of these patients are eventually going to need some sort of emergency surgery, that is an emergency colectomy or colostomy. So first-time attack in uncomplicated diverticulitis, it's usually a low-risk type of situation. You can manage these patients as an inpatient if there's evidence of sepsis, if they're immunosuppressed, if they've got a fever over 39 or significant leukocytosis. You can admit them because they have a lot of pain. Patients who are very elderly, over the age of 70, and have significant comorbidities, those are the types of patients you want to admit as well. If they're unable to eat, and if there's issues in terms of compliance, a lack of a support system for the patient, those social factors will also play into your decision to admit the patient rather than treat them as an outpatient. And of course, if your outpatient treatment fails, then you must admit the patient. Now, there's a lot of debate surrounding, whether having multiple episodes of uncomplicated diverticulitis will increase your risk of complicated diverticulitis in the future, and whether that has an impact on your morbidity and mortality. And essentially, the bottom line here is that in the immunocompetent patient who has a history of uncomplicated diverticulitis, they do not require elective surgery regardless of the number of prior attacks. So they can have 6, 7 episodes of diverticulitis, but if that's a young immunocompetent patient, they do not require surgery. Observation is adequate for these patients. Lifestyle changes are important here. However, the exception is that if these are patients who travel frequently or who live in remote areas or who do not have access to urgent or emergency care, then a sigmoid colectomy may be offered to these patients in those specific circumstances. Now, generally, it is thought that in a young immunocompetent patient, less than the age of 40 and a history of uncomplicated diverticulitis, do not offer elective surgery to these patients. There's no evidence that these patients are going to have more virulent disease. There's no evidence that they're more likely to require surgery in the future. Yeah. However, the approach is different in the immunocompromised patient. In the immunocompromised patient, even with a single attack of uncomplicated diverticulitis, those patients must be offered an elective sigmoid colectomy. So this can be done 6 weeks after everything settles down and you've treated the patient. And the reason for this is because immunocompromised patients are much more likely to develop acute diverticulitis with complications, more likely to require emergency surgery, more likely to die as a result of that emergency surgery. As a matter of fact, the figures show that their risk is about 30% for dying from emergency surgery from complicated diverticulitis, compared to 5% for the immunocompetent patient. So in the immunocompromised patient, you don't hold back a single attack, offer them the elective sigmoid colectomy, get that patient sorted out early. You're going to prevent a lot of trouble in the future. And this is something that must be discussed with the patient. They must understand it, and they will be able to make their decisions, as per your information, right? Now, all patients who have an acute attack of diverticulitis should have a colonoscopy done about 6 to 8 weeks after resolution. And again, I mentioned this before, and the reason for that is that you want to rule out colon cancer in these patients. There are some studies that suggest that the risk of colon cancer in patients who have complicated diverticulitis is a little higher. Whether that has to do with inflammation and so forth in that area, causing causing changes at the molecular level, that is unclear. Right. So we've covered uncomplicated diverticulitis. I'm moving on to complicated diverticulitis. We're talking local perforation here, the hingy twos. Treatment of these patients is based on whether or not the abscess is amenable to percutaneous drainage, that is image-guided percutaneous drainage. And surgery is usually indicated in patients who are not amenable to percutaneous drainage or who do not respond to percutaneous drainage or who fail medical management. So the abscesses that are amenable to percutaneous drainage, they tend to be larger than 2 centimeters. It's very hard to stick a needle into something that's very small. So generally they're more than 2 centimeters. The drainage is done usually ultrasound or CT guided. And done across the anterior abdominal wall. Sometimes it's done across the rectum or the transvaginal route. They put a catheter in, you leave that catheter in until the drainage from it is minimal. Now, with the catheter insertion, there is a risk of fistula formation. While the catheter is in, you can do serial sinograms. And the purpose of that, you're pushing some contrast into the cavity. You want to examine the cavity and see if there's any persistent communication between the abscess cavity and the bowel. If there is none, then you're good. Those patients tend to get better in 24 to 48 hours. However, if they don't, then surgery is indicated in these patients. If they do improve, then you keep the drain in, you take it out when the drainage is minimal, and you offer them elective surgery 6 weeks later after infection resolution and abscess drainage has occurred. Because their risk of recurrence and their risk of having further episodes of complicated diverticulitis is high compared to those with uncomplicated diverticulitis. Those patients who have abscesses that are not amenable to percutaneous drainage are usually those who have abscesses that are less than 2 centimeters, or those who have abscesses which are very close to very important structures, which would preclude percutaneous drainage. We're talking about an abscess that's all mixed up between the small bowel. It's very difficult to get to that without causing a lot of damage. And so those patients initially managed with IV antibiotics. But again, if they do not improve in 2 to 3 days with the antibiotics, then surgery is required for those patients. If surgery is not done, then they must be followed up with serial CT scans until there is complete resolution of the abscess. So this can be very difficult. A lot of surgeons would tend to operate after 3 days if the antibiotics aren't working. So all in all, surgery for hinge 1 and 2 disease is indicated in patients who have residual symptoms or no improvement after IV antibiotics or percutaneous drainage. Those with local perforation, they can usually tolerate pre-op bowel preparation and so forth. So if the abscess can be resected with the colonic segment, do that. Do a primary anastomosis in these patients. So generally, the operation of choice is a sigmoid colectomy and primary anastomosis. You're anastomosing a descending colon to the rectum. You can also do a proximal diverting ostomy if there's a lot of concern about inflammation or contamination and the bowel isn't too edematous. Yeah. One of the preferred approaches is actually to do the primary anastomosis and have a protective stoma. That's much easier to reverse than if you've got an colostomy. So you can do a loop ileostomy in these patients for protection and reverse it later on. To do a one-stage resection, you have to make sure that the bowel is, it's well vascularized, it's not edematous, and that your anastomosis is free of any tension. The distal resection margin in these patients is the upper third of the rectum. So basically where the Taenia coli converge, that's where you know the rectum is. Proximal margin is wherever the colon becomes soft and non-edematous. So essentially you're taking out all of the craggy edematous colon and you're joining up the two ends. The recurrence is about 6% if you do a proper resection. And if the distal sigmoid is not resected, then the recurrence is twice that. So you can see how important it is to know the anatomy and know where the upper third of the rectum begins. Now, it is not necessary to resect all of the diverticulae in the colon. So if you've got diverticulae in the descending or transverse colon, you don't need to take those out. You just need to remove the diseased segment. And the reason for that is that those diverticulae are very unlikely to cause any trouble down the line. They don't tend to cause any further symptoms. When you compare the open versus the minimally invasive approach, um, it's what we would expect from the minimally invasive approach, really. You've got better short-term outcomes, and the long-term outcomes are quite similar. And when we talk about the short-term outcomes, what we mean is that they tend to have less pain, shorter hospital stay, and slight reduction in the complication rates. Yeah. However, there's longer operating times, but overall, the long-term outcomes are comparable to an open sigmoid colectomy. Right. Coming to the Hinchey 3 and Hinchey 4. Yeah. Now, free perforation is life-threatening and it requires emergency surgery. So Hinchey 3 and 4 is almost definitely surgery. Yeah. So if you want to look at the Hinchey stages and think, what do I need to do? Hinchey 1, most of the time, you're going to do conservative management, surgery later in selected patients. For Hinchey 2, sometimes you can do percutaneous drainage with IV antibiotics and surgery, and elective surgery, or you can do IV antibiotics for a few days if it's not amenable to percutaneous drainage, and then elective surgery down the line, or surgery if percutaneous drainage or your conservative management of a Hinchey 2 fails. Hinchey 3 and 4, those are emergencies. They require emergency surgery. There's no ups, downs, or sides about it. And it usually results from either one of two things. You have a localized abscess that bursts into the peritoneal cavity, so you get purulent peritonitis, or where diverticulum perforates and you've got stool in the belly and you've got feculent peritonitis. And the risk here is that there's overwhelming sepsis for these patients. So there are 5 main goals in the treatment of these patients. The first of them is eliminating the source of infection. And what that means is that you have to take out the disease segment, do a resection. The second thing is that you want to minimize any further contamination. And so basically what that means is divert the colon, do a colostomy. The third is you want to control peritoneal infection. So wash out the belly, do a peritoneal lavage, in other words, and the patient needs IV antibiotics. And post-operatively now they need nutritional support, and eventually restoration of the intestinal continuity. Usually this is done after infection resolution, and we'll come into the debate between doing a primary anastomosis versus doing a colostomy. Doing a 1-stage operation versus a 2-stage operation. So the most commonly employed operation in these patients is a Hartmann's procedure, usually 2-stage. The reason for that is that an anastomosis that is done in the setting of feculent or purulent contamination in a septic patient is much less likely to heal, and those patients are more likely to leak. So this is why the 2-stage Hartmann's is employed. You resect the diseased colonic segment, so you typically do a sigmoid colectomy. You've got an end colostomy and a rectal stump. And then in the future, about 10 weeks on, you can then reverse that and join the descending colon to the rectum. Sometimes mucus fistula may be created, but again, closing that colostomy is technically difficult, and colostomy reversal only happens in about 50 to 60% of these patients. And again, it's usually done about 10 weeks on. So What's the other option? The other option is that you can do a primary anastomosis. So, in other words, the drawback, the safest thing to do may be the two-stage Hartmann's. Resect, give them an end colostomy with a rectal stump, and come back and reverse that later on. That may be the safest way to go. The issue associated with that is that the rectal stump can sometimes be very difficult to find. You've got to go in for a second operation. There are a lot of adhesions, and you can the risk of that operation is a little higher when you're trying to reverse it. And other times you may not have the length of colon to bring down. You can still have tension and anastomosis and so forth. So one of the other options is to do a primary anastomosis with a protective ostomy. And again, this is done much less often, but this is where you can redo your resection, anastomose the descending colon to the rectum, but do a covering ileostomy instead. Yeah. So there's a few opinions on this from Zeng et al. And Constantinides, I'm butchering that name completely, et al., who have the belief that this may actually be the optimal strategy in some patients. Now, when would you opt to do a primary anastomosis and a proximal diversion? Well, it's better suited to patients who have minimal fecal contamination or minimal purulent contamination, those who do not have evidence of sepsis, those with limited comorbidities. So in other words, you're doing it in a patient that's rather well. Yeah. Elderly patients who are who are septic, where there's a lot of contamination in the abdomen, they're probably not ideal for these types of operations. Some work has been done on laparoscopic lavage. By and large, this is not superior to any of the other methods that I've mentioned so far. But there's some evidence that it's feasible for patients with purulent peritonitis, and in some small studies, it's been shown that there's similar complication rates and the risk of reoperation is quite low. But in some other studies, it's shown that the risk of reoperation is higher. So there's a lot of controversy about this, and this is not one of the recommended courses of treatment. Systematic reviews so far have found that major complications occurred more frequently in patients after they had laparoscopic lavage versus a sigmoid colectomy. The early reoperation and mortality rates were similar, but you've got more complications. It's probably not a good way to go. Yeah. If a surgeon does opt for laparoscopic lavage, they have to choose their patients very carefully for this. You have to exclude fecal contamination, which means which you should be able to do when you do your laparoscopy. You've also got to do an intraoperative sigmoidoscopy to ensure that there's no evidence of cancer and that there's no ongoing colonic leak. Because if you miss a cancer here, a concurrent sigmoid tumor, and there's a perforation, there could be seeding, you could be worsening the patient's prognosis by doing this minimally invasive procedure. Also, the patients chosen for this are patients who must be able to tolerate ongoing sepsis or recurrent infection. The likelihood of getting recurrent infections is quite high. So frail elderly patients with a lot of comorbidities, those are not good candidates for this sort of approach. So again, the urgent sigmoid colectomy is required for patients with diffuse peritonitis or in those in whom non-operative management fails. You've got to try and restore the continuity of the bowel at some point in time. It's usually recommended to be done about 10 weeks later, but ultimately it is up to surgeon preference. The only time where you would opt not to operate on a patient with purulent or feculent peritonitis in those patients who are not fit for surgery, so very frail, very elderly, very sick patients. Um, One of the other options described by Narayan Singh et al. As well as Kronborg et al. Is doing primary suturing with a ornamental patch. It's really Kronborg et al. Uh, that described this. Narayan Singh reported satisfactory outcomes in patients with perforated left-sided fecal peritonitis who had primary closure and primary anastomosis. Now, in the decision-making process for emergency surgery, when you try to think about the prognosis of these patients, there's a lot of classifications and so forth that can come into play. Of course, you've got the Hinchey's, and then there's something called the Mannheim Peritonitis Index, which assigns scores here to these patients based on a number of things, the age, gender, organ failure, peritonitis, what the exudates look like, and so forth, as well. And there's ASA classification, as we know. But what has been found is that the long-term outcomes are really only affected by the ASA classification and the age of the patient. All of the other things don't really play a part in terms of the long-term outcomes of these patients. So moving away from the Hinchey's and the peritonitis and so forth, we now come to fistulae. Because we know complicated diverticulitis can lead to fistulae. The most common type, of course, is colovesical fistulae. Colovaginal follows second. Coloenteric, colouterine, and colocutaneous fistulas are much less common. The fistulation to pelvic organs actually occurs in about 10% of cases of diverticulitis. So when it comes to colovesical fistulas, diverticulitis is the most common cause of colovesical fistulas overall, and it may be diagnosed with CT. So you can give oral or rectal contrast, or sometimes you can do a CT cystogram as well. It's a pretty good diagnostic tool. You can find air in the bladder, and that's usually indicative of a colovesical fistula. But in addition to that, these patients also need colonoscopy. Now, colonoscopy is not usually able to detect the site of the fistula. It's not done to delineate the anatomy of the fistula, but it is useful in helping to exclude Crohn's disease and cancer prior to surgery, because that's going to affect the type of operation that you will plan to do. The other investigation is cystoscopy. Again, it doesn't often find the site of the fistula, but sometimes it may be able to see bullous edema and localized inflammation, and those signs are thought to be diagnostic of a colovesical fistula. But more importantly, it helps to exclude bladder cancer. It can also give you some information about the location of the bladder lesion with respect to the ureteric orifices, because if you've got a bladder lesion near the trigone, then ureteric stenting is indicated. And it's also indicated if you suspect that this is going to be a difficult operative case. So how do we manage these? So ordinarily, these fistulas are divided, and you've got you resect the involved portion of the colon. Usually, it may involve resecting a part of the bladder as well. So you can resect the colon, do a primary anastomosis, and for the areas of the bladder that are resected, you can do a primary repair. You've got to keep the catheter inside you, the urethral catheter, of course, inside you for 7 to 14 days, and that's to reduce the risk of a bladder leak. Non-operative management is opted for in those patients who are poor surgical candidates. Those patients have to be managed with prophylactic antibiotics, but the problem with this is that it risks resistance to the microorganisms. However, you've got no other option in these patients. When it comes to colovaginal fistulas, again, diverticulitis is the most common cause of colovaginal fistulas. It's more common in older women who've had a hysterectomy at some point in time in the past. And again, CT is useful for looking at complications of diverticulitis, but it doesn't really delineate the anatomy. Again, you have to do colonoscopy to rule out Crohn's disease and cancer. But in these patients, the clincher to defining the anatomy of the fistula is performing an anorectal and vaginal examination under anesthesia. This patient needs an EUA, preferably with the presence of a gynecologist to do the vaginal examination. You do the anorectal examination, and you can try to delineate the anatomy of the fistula that way. And these patients, the best treatment for them is a sigmoid colectomy with a primary anastomosis. Close the fistula tract. You can also reinforce it with an omental patch. Post-operatively, these patients need to refrain from sexual intercourse or inserting anything in the vagina for about 6 weeks. And again, those patients who are post-surgical candidates, you can opt for non-operative management in those patients. The risk of overwhelming sepsis in a patient who develops a pelvic abscess as a result of a colovaginal fistula is actually quite low. So non-operative management is relatively safe in these older patients who tend to be post-surgical candidates. All right. Going on to coloenteric fistulas, these should be suspected if you've got a patient with known diverticular disease who suddenly develops watery diarrhea. It's usually chronic, crampy abdominal pain. They also experience a lot of weight loss. And again, CT is the best mode of diagnosis here. You're doing your colonoscopy again for the same reasons as mentioned a million times before. And in these patients, the most common area of the bowel that is involved, small bowel, is the ileum. Second most common is the jejunum. So for these patients, you do a colon and small bowel resection with primary anastomosis in both the sites. Yeah. And then finally, well, not finally, but we come to bowel obstruction. I'm not going to go into this too much because it ties into the principles of bowel obstruction in another lecture. So acute diverticulitis and colon cancer can both cause bowel obstruction. It's very difficult to differentiate between them on CT imaging. So surgery is required in these patients, 1, to relieve obstruction, and 2, to rule out cancer. Complete obstruction is not very common in diverticular disease. But when you do your resection, you're resecting the involved segment, so the sigmoid colon, and you can perform a primary anastomosis. Sometimes if the resection cannot be performed safely, i.e. you've got a patient who is hemodynamically unstable, then just a proximal fecal diversion, so i.e. an end colostomy may be adequate for those patients. There's no rule for endoluminal stenting in these patients, because there's a higher risk of perforation, stent migration, and recurrent obstruction. So stenting is out of the picture for these patients. Right, and finally, we come to colonic diverticular bleeding. This is very common, especially in the elderly population. It is the most common overt cause of lower GI bleeding in adults. It accounts for about half of all the cases of lower GI bleeding. Now, these patients tend to be above the age of 70, having diverticulosis on both sides of the colon, as well as things like obesity increase the risk of bleeding. Now, most times, and that is to say about 75% of the time, the bleeding stops spontaneously. The pathogenesis of this really is that as a diverticulum who needs a penetrating vessel and is responsible for the wall weakness at the point of the herniation. It drapes over the dome of the diverticulum. It's separated from the bowel lumen only by the mucosa. So as the vasa recta are exposed to recurrent injury along the luminal aspect of the bowel, you get intimal thickening, but then you get thinning of the media, and that leads in segmental weakness of the artery and predisposes it to rupture into the lumen. It is rare for bleeding to coexist with diverticulitis. And most patients, this bleeding happens on the right side of the colon. About 50 to 90% of patients with diverticular bleeds, it's coming from the right side. Yeah, it's thought that this might be because the right side of the colon is thinner, and so the diverticulae may have weaker necks and domes, and that may predispose to more vasa recta injury. As I said before, the bleeding stops in 75% of patients, and in patients who receive a little less than 4 units of blood in a day, it stops in 99% of them. But the risk of rebleeding is about 14 to 38%. Now, if you get a second bleed, then your risk of rebleed jumps up to as high as 50%. And so it's generally after a second bleed, a recurrent episode of bleeding, that surgery is offered. Yeah. So the tenet here is to consider surgery for those with multiple episodes of diverticular bleeding who are good surgical candidates, because the morbidity risk is 10% and the mortality risk is about 20%. So it's pretty likely that you're going to die if you keep on bleeding, and it doesn't take a rocket scientist to figure that out. How could this be diagnosed? Clinically, of course. Sometimes colonoscopy can be done. Nuclear scintigraphy scanning, that is a targeted red cell scan, can also be of vital importance. CT angiography and good old regular angiography can also be done. Initial management of these patients is resuscitation, the ABCs. Get IV fluids, get blood products on board. Assess for coagulopathies. If there are, treat them. Put down an NG tube, do a gastric lavage, and exclude an upper GI bleed. If the patient is high risk, that is, it's an elderly patient, low HP, hemodynamically unstable, those patients should be managed in the ICU. One of the options for therapy here is endoscopic therapy. So patients with a suspected lower GI bleed should have colonoscopy. Now, in our system, that's not always available at all hours of the night. But it can be useful to identify active bleeding. You can, if there's a visible vessel, you can attempt endoscopic therapy. This is preferably done by an endoscopic team that specializes in GI bleeding. The outcomes are better when it's performed by a highly specialized team. But the procedures that can be done, you can do 4-quadrant submucosal epinephrine injection. There's endoscopic tamponade. You blow up a balloon and hold it there. Bipolar coagulation, apply hemoclips, or do endoscopic banding. If the bleeding site cannot be identified with colonoscopy, or if your endoscopic treatment fails, then you may consider angiography. Now, angiography can detect bleeds greater than 0.5 mils per minute. But in order to do so, it must be performed during an active bleed. Now, doing a tagged red cell scan before angiography may help to narrow down and assist in identifying your bleeding site. And if angiographic therapy is undertaken, it usually involves embolization of the vessel or the infusion of vasoconstricting agents into that particular area of vasculature. Now, once it's technically feasible, 95% of the cases achieve hemostasis. But the big drawback here, and it's a big but, rebleeding happens in 56% of these patients. Yeah. So then we come to what we like to do, which is surgery. So there are 4 main indications. If the bleeding does not stop spontaneously, if angiographic or endoscopic therapy fails, if the patient is hemodynamically unstable despite aggressive resuscitation, and in patients who are good surgical candidates with recurrent episodes of bleeding. Surgery is required in about 18 to 25% of patients who require blood transfusion. So the more blood you need, more likely you are to need surgery. That sort of thing, probably. Now, what we do is a subtotal colectomy. Yeah. Now, a segmental colectomy may be considered if the bleeding site has been localized with endoscopy or with angiography. Red cell scans are not accurate enough. The rebleeding rate in these patients is 0 to 14%. Never, never do a blind segmental resection. It has a very high rebleed rate, 40%, very high rates of morbidity and mortality. You're just blindly taking out a segment of the colon. That's never good. Yeah. But subtotal colectomy is reserved for patients without a documented site of bleeding. And in our local setting, that's very often the case. We don't have a documented site of bleeding. And what is done is a subtotal colectomy. You leave a rectal stump and do an end ileostomy. Yeah. Very often these patients are too unstable to perform an anastomosis because they're bleeding out. It has a very high morbidity rate, 35%. The mortality rate is 11 to 33%, but without it, the mortality rate, as we've seen in the paragraph above here, is much higher. But the rebleeding rate, and this is the clincher, is virtually 0%. So once you do a proper subtotal colectomy, and there's a rectal stump down there, and you divert with an ileostomy, you can go to bed safe at night and not have to worry about bleeding again. You just have to worry about your patient getting blood and making it through the post-operative course. Yeah. So that's it really for diverticular disease. So yeah.